Well, good morning and welcome from all around the world to Structural Heart Life Cases, broadcasting directly from the Mount Sinai Fuster Hospital in New York City. My name is Pedro Moreno. I am a professor of medicine and your moderator today. And remember, this is an interactive experience. So we want to hear from you. You can send us your questions directly from the website ccclifecases.org or from the PubMed. And this case, as well as the other ones, will be available today. Now I'm going to transfer you to the team that is very excited about this fantastic case. Go ahead.
Yep, the CCC Live or YouTube and everywhere, we want to make very interactive. We want to make it very interactive and start with a new year. And we'll have a new video also, which we made it, and it was very successful. Our live New York transcatheter valve conference, we did a total 9 live cases. 9 live cases in a day. So came out fantastic. And with the strong demand, we are now making this since last July, the experience every month. So with that note, let's try to bring everything, a case. It's a unique aspects of teaching and operational, understanding. And this is the case for today. If we can start with our slide presentation, we just want to, before that, let's go back. Let me just introduce, although we all are the regular faces, but Dr. Keeney, Dr. Gilbert Tang, Sahil Khera, and we have our interventional fellows. We actually have 3 total structural fellow at this year. Next year will be 4, huh? Yeah, 4. Yeah, next year will be 4, and rest of the staff, and then of course anesthesiologist Dr. Eric Freed. Okay, with that, and then on the our echo will be Dr. Larakis.
Yes.
Good. Okay, so this is a case, little interesting in the sense that is a failed BioBentall, and the patient was done, young patient, as you can see, 61-year-old. Patient had a valve, Bentall, in 2015. So with the 23 Magna, so we are talking about just 9 years, but have multiple comorbid conditions with the mutation, with the COPD, diverticulitis, portal vein thrombosis, recent heart failure admission, and EF of 40%, and the structural valve deterioration with minimal transvalvular regurgitation, and on good medical therapy, coronaries are normal, sinus rhythm. So question will be this young age, and this is where in the didactic discussion I'll have a lot to show that what is going on with the young patients. More and more are coming to us and they getting this transcatheter option. So this patient has a T transthoracic echo, and you can see here, which we'll probably going to show you the live, and the coronaries were normal. So maybe if we can show the live echo first.
Yes. Thank you, Dr. Sharma.
Show the echo, please. Yeah.
So this deep gastric views of the left ventricle. As you can see, the ventricle is severely dilated, severely decreased function, looks worse than the 40% that was before, and also no pericardial effusion. Measured here by 3D is 33% actually, the LVEF. Also the right ventricle is severely dilated with severely decreased function. It has mild to moderate TR with a PA pressure about 50 millimeters mercury. Severe mitral regurgitation, as you can see here. A clean left atrial appendage. And this short axis view of the aortic valve, as you can see, severely degenerated prosthesis with minimal aortic insufficiency, valvular. This X-plane of the valve, and this with color, again, minimal valvular AI with severely decreased function and severely degenerated prosthesis. Peak gradient we got today, velocity 3.8, mean gradient of 37 millimeters mercury. By continuity equation, the aortic valve area is 0.4 centimeters square, stroke volume index 18, so it's a classical low flow, low gradient, prosthetic aortic valve stenosis. We measure with 3D the annulus, and the area is 3.6, the perimeter of the annulus is 6.8, and this is the aneurysm of the aorta, of the ascending aorta, that we see here, and this was reported before in the past. Thank you very much.
Okay, so basically, but you are also saying that patient has a severe MR?
Severe MR, yes.
And what about the TR?
The TR is like mild to moderate.
Mild to moderate. So
yes.
question always comes that this kind of patient ideally should go for multivalvular disease in young patient. But if the surgeon say, no, it's very high risk, then we have to come with a percutaneous option. Gilbert, you want to comment on that? How
Yeah, so we just had a recent heart valve collaborative workshop on this subject because there are no guidelines, right, tackling all these kind of patients. So basically the decision making is the patient high surgical risk, for example, in this case for double valve surgery. If the answer is yes, then the question is the transcatheter option available for each valve, right? So in this case, the aortic valve is pretty straightforward. It's a prosthesis valve. Patient already had an aneurysm. You can actually see the aortogram is quite impressive, the residual aneurysm. Patient was deemed by a multidisciplinary surgeon has high surgical risk, so we'll do the aortic valve first. Now, Stam, can you tell us what the mitral regurgitation mechanism is? Is it primary or secondary?
Yeah, this is secondary.
So secondary MR, it might improve with GDMT, right? Because you said the LV is dilated.
Yes,
now, if not, then we'll explore potential either even surgery or transcatheter option, repair or replacement. So now we have a lot of different options to explore for these high surgical risk patients.
Yeah, also to add on that sometimes the MR gets better after we fix the...
That's right. As in the context of primary hypertension and volume low.
And does the patient have pulmonary hypertension now?
Yeah, the PA pressure here today is like 50 systolic PA pressure, yes.
So kind of moderate. Okay, let's go back to our presentation now. Okay.
Clean the wire.
So this one.
Clean the wires.
So these are coronaries which we showed. And so this is now the CT on this patient, yes.
So you can see the patient had a 23 Magna surgical valve. You can see the inner diameter, the true ID is around 21 and change. You can see the LVOT is a little bit bigger. Next slide. So you can see the patient ascending graft, right? This is a BioBentall. So the entire aortic root has been replaced, and you can see the aortic coronary arteries actually re-anastomosed to the graft itself. So that's why you can see the sinuses and the coronaries are so big, and there's no issue of coronary obstruction, obviously, in this case. The question actually we'll talk about later is what to do with this patient. This is a 61-year-old in terms of lifetime management. Next slide. So you can see the CT scan of the valve. Next slide. You can see some of the valve to left main distance very generous. Next slide. So you can see this is what we're talking about here, wrist plane. So if we put in a SAPIEN-3 today, you can see the neoscript in the green line. That's where it's going to be top when the next valve will be determined. Okay, so the coronary wrist plane, the CRP, is where the coronary, that's more for coronary access. You can see there's no issue with coronary obstruction here with redo TAVR. In the future, if you do a SAPIEN first and then an evolute later. Okay, next slide.
So because this patient is 61.
Yes.
So likely will get us on
two more valves.
Normal.
Yeah.
So likely we'll need 2 more surgery.
That's right. Now here, if you use an evolute or self-expanding tall valve first, you can still do that. You can see that here, but depending on if this valve fails, you have to decide where you're going to put the second valve with the SAPIEN-3. If you put it too high, you may lead to coronary obstruction. On the right screen, no 6. So you're going to have to put it in lower. But the caveat also is once you put the second valve, that the short and tall combination, coronary access will be very challenging because now you have 2 valves in place and you have a tall valve, a short and a tall, and the leaflets are pinned upward. So that's why I think in our case, based on this analysis, and you can do this on the first CT like we see here, that we think a short valve first and then a tall valve later, if it fails, will probably be the most reasonable option. The other thing I want to tell the audience that this is a BioBentall. You cannot fracture the valve. If you fracture out, you can lead to AV disruption with aortic root rupture, and that has been described before. So you can fracture the valve if it's just an isolated AVL, but if you have a root enlargement or if you have a root replacement in this case, you cannot fracture. So we have to optimize the procedure on this first valve.
Very good. So now question comes. So basically because of lifetime management, we thought we do the short balloon expandable valve now.
Yes.
And then followed by the self-expanding. But what if getting another balloon expandable after 10 years?
The issue that time, in my mind, will be the prosthesis-patient mismatch because you cannot fracture.
Okay.
So
very good. Okay. So therefore, this is what we decided in this patient using the balloon expandable valve. So commissioner alignment.
Yes, that's so you can see the surgical valves and the access should be straightforward.
Access is straightforward. Now, what about 2 things? The one, anesthesia. Second is sentinel.
Right.
Let's comment on it. Why patient should get intubation?
So this is a young patient. We want to make sure we have no respiratory motion to, allow the valve to move, especially for redo TAVR, but this is a TAVR stuff. Second point is that we want to see if the LV gets better, right? If you want to see the MR gets better. And then also make sure there's no paravalvular leak and the valve gradient is good. So we'll go do hemodynamics as well, I think, afterwards. So, but yes, some patients can get under MAC instead. But I think a young patient, it would be a disservice if we have any problems with this first valve, because this means that this first valve that we put in, this first TAVR, will degenerate faster. It's going to fail earlier, and that's not what we want, because last 10 years, so the patient had a surgical valve at 51.
Yeah.
Right? That's very good, actually, for a 10-year durability for the first surgical valve. So we're hoping that for TAVR will be also similar.
Okay.
And the sentinel, we did the sentinel. Sahil can show you later on.
Yeah.
So, yeah.
And the indication for sentinel now, I know we have become a little limited. Sahil, tell us which case would you use the sentinel device nowadays?
Young patient, it's a very degenerated valve. I'm a little concerned about disabling stroke. So we will also show you crossing, because using my favorite catheter here for these degenerated cases. So I think Dr. Sharma, sentinel for valve-in-valve, especially degenerated, calcified surgical valves, is not unreasonable.
Yeah, and redo TAVR as well. We also like to do them.
And the redo towers.
Yeah.
Okay. So those are the cases you'll need. So let's complete it. Go to the fluoro. So let's complete this. 61-year-old female with the BioBentall degeneration.
Male.
And coming back for the second valve because of comorbid conditions. Surgeons decided that go and do the TAVR and maybe the mitral clip emptier later on. So that's where we are now. The TAVR using 23 millimeter SAPIEN-3 Ultra Resilia for failed
Shock.
No,
just pull the camera.
Shock.
Yes.
Everyone, hold on, charging,
Good.
clear.
Yeah.
Okay, we're having a BTRS, so we're going to
No, the wire.
Okay,
let's go.
That's some catheter induced. Yeah.
No, it's not.
It's not
catheter induced. No. Guys, we're going to go ahead with the valve. You keep
Go
talking.
to the hemodynamic.
Okay, beautiful. Just come back. So the first question, Dr. Sharma, from Boris Vesga, Colombia.
Right now, can we?
Yep. We good?
Yeah.
This,
What?
Let's just finish the case.
I'm
Do
sorry.
your lecture or something. You got to come out.
Good mag out.
Yeah.
just expand a little bit between the balloon expandable versus the self-expandable in valve and in this case, as you already did.
Yeah, we go through discussion. Okay. So let's. So while they are getting this patient settled, the rhythm settled, which may take few minutes, we'll come back to it. So let's go to our presentation today. We continue. So they basically, and these are the points which I have already briefly spoken here, and that is particularly the patient who has AS plus management of the data on the aortic stenosis, who should get surgery, who should get TAVR, and what type of the TAVR usage and so. We are ready for the valve.
Okay, stable.
Yeah.
Anything bad happens, you have to go offline.
Why? What a gradient. You want to just ready for the valve replacement?
Sure.
TAVR.
So this patient has valvular cardiomyopathy.
Let's go back to the live case again.
Fluoro and hemo, please. And also, yeah. Great.
Yeah. Look at the gradient. Whoa. This is artificial because we give some medication or what? Such a gradient.
No.
No, we didn't give any medication.
But we didn't have that high gradient by echo.
So you want
by
About 200, 100 plus.
By echo, before velocity was like 4.1. Today was 3.8. Mean gradient was about close to 40. Mean gradient. But
okay.
You want me to take a look of the?
And to show it what you are trying to show on that fluoro?
No, we were because remember it is a BioBentall, so you do have the graft. So many times the graft will not allow us the manipulation of any catheters. So we just tried with a diagnostic. Okay, yeah, here you see that.
Oof.
That's how it looks on the angio. Yeah. So regular diagnostic catheter we tried. For prosthetic valve, we always say go use AR1. We tried AR1, would not even, it goes there, but we know it does not face the center of the valve. We changed to AL1 diagnostic, did not help us. So then we just went with the guide. So more stable. You see there, you just have to be at the center and then able to cross
This is
the
what,
valve.
AL1 or AR2?
AL1 guide. Yeah.
Okay.
Yeah. I think the challenge was that the graft.
Yeah. And
So we are there inside now.
And patient has valvular cardiomyopathy, so went into short run of VT, was shocked out of it, very stable.
I think most likely the high gradient is they gave some epi, so most likely that's what.
So also that you can use, that's the advantage of Dr. Sharma's questionnaire. Why would you use TE here? You can actually, TE can help you guide the opening, especially for redo TAVR. We had a live case before where we show you can actually cross accidentally outside the valve. And you might not know. So that's very helpful even for surgical valve. It can help you, especially for very stenotic valve like this, to know where to cross.
Yeah.
So we've done that before as well.
Good bets.
So Gilbert, we are just going to pre-balloon, but you're saying we are not going to crack, right?
Yeah, we cannot crack here, but we should look at the gradient. So one of the reasons why we pre-balloon, what people ask, why do you need to pre? There's a big aneurysm there. Tracking is going to be difficult with a small synthetic graft that you saw in the aortogram. So you don't want to get stuck and cannot cross and then cause damage to the SAPIEN valve and also the surgical valve. Because remember, these surgical valves now are quite friable. Even though with protection, on cerebral protection, you can also go in the peripheral, in the distal embolization. So you definitely don't want to do that. So this allows us to see and get an idea. Now, of course, you can see the team here.
And the valve is ready.
They're getting ready for the valve ready, right? In case of acute AR. So that's very important as well.
So one of the challenge could be with that now since you saw that couple of catheters we needed to cross the valve, because of the
pace 180.
Right, graft. So we may have to have challenge even getting the
look at that.
Off.
Look at the waist initially.
Get me the valve.
So, and we have two fellows, Taka and Penta, so always keep holding the wires. Very important, guys.
Get me the valve.
Yeah, now is not the time to pull the wire out.
Very important now.
Okay, pressure is getting...
Is the AI mode now?
Yes, probably.
I'll do it.
They don't want us, Dr. Sharma, to go in. I want to look, but I don't want to...
Yeah, pressure is a little soft, so let's get going. Especially in the context of low EF. If the patient normal EF will be less worried. We've seen some of these cases before. They just can't tolerate the more AI because especially that's why it's important to understand the mechanism of failure in the first place. This patient has mostly AS.
Yeah.
So then you have acute AR from the ballooning, especially if you plan, let's say, fracture, you have to be ready with the new valve because otherwise the heart's not going to tolerate with a low EF. And then that's when you have to get in trouble.
We are fixing it.
Gilbert,
which we expected. Good.
Question also is now advancing the tower, self-expanding versus balloon expandable, right?
Yeah.
You have to make sure the advance.
Which one would be easier in this particular case?
No,
definitely
here with the since we are going to have the.
Go.
Show me up. Go ahead.
Go ahead. So you can see we need to make sure we're not stuck in the aneurysm. Good. See how easy it is? We'll save that. Okay.
Okay. Flex.
Everything's off.
Okay, let me flow safe.
Good. Hold the wire.
Yeah, I'll hold the wire now. Good. So it's a little bit high.
Go in slightly.
Dr. Kinney?
So what are you looking for? Teach the audience, what are you looking? The dot at the lower portion of the Magna valve?
Okay, we are having...
Yeah, we're going also VT again. Just be careful.
Let's deploy it now.
Okay.
No.
You think we are good?
Yeah.
Pace 180. I'm going up.
Make sure it doesn't go up.
Careful. Wait.
Good,
okay,
good.
go up.
Going up.
Yep.
Okay, good.
Okay, nail it.
Nice.
Go.
Good.
Done.
Good.
Okay, stop. No, man. Okay, good.
Keep pacing.
Off.
And wait.
We'll double tap.
You want to do a...
Double tap.
One more. But question is, one more CC or no? Let's see the...
Give me the wire for the pigtail.
Give me one more CC, please.
Yeah. So see that there is a dent in the lower portion. It's still there.
Yeah.
Which will be because the true ID is actually smaller than your
Right.
valve,
and you cannot fracture. So that's why, we're not trying to fracture here.
21.
So.
The mean was 21.5. Something.
Yes, that's right.
Yeah.
You're in the bulge.
Yeah, because that aneurysm and that the tissue, the combination, it will require a little manipulation of the catheters. Yeah, this is the anastomosis there.
right there. Good, perfect.
That's good. Yeah.
While we are doing the aortogram,
Clean
Pedro,
the
this will be the
wire.
right
Yes.
time to get the question. Yes.
Oh yeah, we have several. So the
Yeah.
first was between the balloon expandable and self-expandable in VIV or in this patient particular. Yeah.
Yeah, which they explained very well,
would
right?
just do the
Because
same.
of the
I would not add
lifetime,
more
if you
to
put a
it.
balloon self-expanding now, your choices will be limited unless you are very precise to the node 4 or so in the future. So better is balloon expandable now and self-expanding in the future. Next.
Base 180.
Yeah.
Yeah. Second,
Also, Pedro,
Yes.
same with the self-expanding, we would not have been able to navigate the
Corners.
TAVR valve the
Correct.
way we did it with this because of the flex catheter. You see, we were able to. You see, just with the diagnostic catheters, we are having a lot of trouble.
Hemodynamics.
Yeah,
first
yeah.
of all,
Yep.
so in
Take
Bentals, you recommend balloon expandable.
No, not necessarily,
Not
but,
necessarily,
but for
but
this
prob-
particular patient, because
For this
patient is
particular.
young, 61-year-old, with the aneurysm, that's Dr. Kinney has mentioned in terms of tracking, we think
Yeah.
the cell balloon expandable valve with the extra flex allow us to have more maneuverability. As you saw here earlier, even the pigtail had trouble getting into the. So you imagine if you don't have an active flexion, it can be challenging. Now, some self-expanding valve have a more flexible system, but they are not approved for valve-in-valve yet. So the Navitor system is not approved for valve-in-valve. The Evolut is, but you might have trouble buckling, and then you might have trouble tracking and deploying. So
Fantastic. So second question for Dr. Fenisola in Venezuela is regarding anticoagulation in this case, and if you plan to do a CT scan follow-up for this.
Yeah. The question is this valve in valve. I mean, this is always questionable. We favor anticoagulation maybe for short term, but we are not doing routinely because there is no routine guideline. But yes, many of them are getting the CT scan, either discharge or at 30 days.
yeah, for TAV inside, we don't do it routinely, but for TAV in TAV, we definitely do because we want to make sure that, how it looks because we're still learning. But this one, we won't necessarily do a CT unless you're concerned.
Yep.
But to Dr. Sharma's point, typically 3 months anticoagulation.
Anticoagulation,
Yeah.
3 months.
3 months, yeah.
Fantastic. So questions for Dr. Echeverry in Colombia. We already answered. The fracture here is not indicated.
Yep.
And the sentinel was indicated because of the tortuosity. And finally, he's asking if eliminating the jet will improve the aortic, dilation that this patient has above.
A very good point. So ascending aorta where it was attached, it was like 5.8. It remained the same, didn't change. So that part, so that function of the valve replacement of the BioBentall remained good. So no change on that point. It was all just the aortic stenosis. And of course, we did a sentinel largely because of the valve in valve and all these, they have high chances of embolism. And like you look at the gradient, fantastic, anything single digit. Now we see on our side is 0 and echo will say about 6 to 8 millimeter gradient. Okay.
Yeah, let's have
Let's
Sam
go
report.
over
Yes,
the
sir.
indication for sentinel again. That was there thing also.
So
Yeah.
Sentinel, all the data
it's better.
so far have been negative. We used to be doing a lot more Sentinels till last year. We've sort of changed our practice, but still do it in heavily calcified anatomies, valve in valve, and patients who have AFib with a high Chats-VAS score.
And bicuspid.
And bicuspids. But apart from that, we have moved away from using it routinely. And so has the entire US. Actually, less than 15% Sentinel use in the United States, if you think about it. And the other countries, it's almost 0, especially in Asia. So I'm not sure how it is in Latin America, Dr. Moreno. But that's our practice.
Yeah, very low. There is a few other questions, but I don't want to interrupt you. Let me know if you should go with
No, you
questions.
got your questions.
Let-
We are ready for
Okay.
the questions.
Let's
Keep going.
have Stam tell us how it looks now on
Can
echo.
you put a,
Can you show echo for us, the audience,
Yeah.
please?
so this deep gastric of the
Echo here. Good.
deep gastric of the aortic prosthesis? Can you put some color? Yeah.
Yeah.
It's trivial PVL, and we measure the velocity mean gradient of 6, a peak gradient of 11.
Okay, beautiful.
No pericardial effusion.
How does the
Actually,
LV look
EF
and how does the MR look?
The EF is much better. The EF improved significantly. I can show you.
Okay, yes. we
Yeah,
see
this
that.
was valvular cardiomyopathy.
And did the
so-
MR get better?
That's the MR. Can you put some color, please?
Show the MR.
Beautiful result.
Oh,
Still there.
Yeah, still there,
Decreased.
but yeah, we can. We'll take care of that. Yeah.
Yeah, that's a bit of a pseudo prolapse on the anterior leaflet, so we'll have to see at 30 days how it looks after
We'll take some,
GDMT.
3D
So it
images
might have
after.
to be
Yeah.
But we will definitely have to be addressed. So
Okay, Pedro, start the questions.
Yeah, complex question here. We're dealing with a patient with this methyl entatrine hydrofolate reductase mutation, MTHFR. Now, this mutation is characterized by the homocysteine trouble, and so it is indicated to replace, with folate, whatever, for the homocysteine for her mutation. The question is, for this anticoagulation, should we anticoagulate here independent of the mutation, which is it has its own indication for treatment? Would you guys anticoagulate?
Yeah, this case we'll do for 3 months.
Excellent.
And whether you give folate or not, every trial of the folate at one time at the peak for the coronary, this all failed. So, patient taking folic acid, even high homocysteine trials with the folate have failed. So, I'm little skeptical. I think everybody should take little folate. That's probably good for your RBC production and the hemoglobin. And I don't know whether it work on the homocysteine or CAD production or, protection of the CAD or for any valve degeneration.
Yeah, so this was Dr. Bernardi from Argentina. Also about the previous thrombosis the patient had. It was a vein thrombosis, is that correct?
Yeah.
Portal vein thrombosis.
Portal vein thrombosis, yeah.
Okay, very good.
Beautiful. Measure that. Yeah.
All right, so far so good. Now you want to do good aortogram has been done, or we want to do it now? Hemodynamics done, let's take it out, do a good aortogram. Just show the little ascending aorta also, that dilated one. And then we go to our presentation.
Yeah. You can start your presentation. We will be ready with the aortogram.
No, but do aortogram. We need to show aortogram.
Yeah.
I'm still believer of the angiogram. Die.
Okay,
Body
T
likes the
can
die.
come up.
Side by side, yeah.
Okay,
T
T
up.
up, please.
Yes.
Yeah. But the key is that you want to bring residual gradient to single digits, and that's what we did. So if not, you go with a bigger balloon, higher pressure, and so forth post valve deployment.
Okay. Low mag.
no,
Give some extra volume. Volume
Yeah.
is very low, right? 8 versus you give more.
Yeah.
Low mag is good, yeah.
This is good, no? You
One
want
second.
aortic.
1 second.
Arch. Yeah.
Okay, ready? Ready?
Yeah.
Yeah, go ahead.
Very nice.
All
Wow.
done.
Not even a single RBC going through.
Yes.
Look at that. Oi, haha. No PVL, central, peripheral, in between, paravalvular, nothing. But aneurysm is the same, unchanged. So this is it. Okay. With that note, the completion now.
Let's get some much.
The Sile is going to take the central out first.
Sentinel followed by
Yeah,
close.
sentinel and the groin
Okay.
axis, yeah.
Good. So we'll show if something unusual you see, the wall tissue on the sentinel, little chunk, then we can show to the audience. Otherwise, it's a usual thing. You'll always find a micro debris in 99% of cases, but the macro debris happens maybe in 20% of cases. But as we saw, the many
wires
trials
have
are questionable, and therefore the use has gone down of these valves, particularly the cerebral protection devices. Now, still there are trials. The field is still evolving. We are the part of the Protembo trial, which is the shield from the left radial, and we are part of it. It is trial is still continuing, where the future will need to be seen. So next, please, slide presentation. Good. So what I'm going to talk about, which we said earlier, that more on a younger patient and what we are going on, and we have the data of the balloon expandable tower with the Resilia, and then the SOLVE-TRAVI trial of the balloon expandable versus self-expanding. Now, as we all know, the area of this, the age had been evolving, and part of that is evolving because we are saying it's going to last for 10 years. So if it is for 10 years, then question comes that if somebody is going to live 20 years versus less than 10, we have clear decision that in those cases you should get less than 10 get TAVR irrespective of the age, more than 20 they should get surgery. In between, shared decision making, and of course in the Europe it's a 75 years. Now, and that has led to a class 1 guidelines and so. Now, but what happens in the real life? Almost half of them in less than 65 years of age. In America, half of them are getting the TAVR. Now, question is why? And this is a big question. And we know, like this particular case, because patients are so many comorbid conditions. So in the past, nothing was being done, but now at least the TAVR being done for these patients. And this is where we are, that many of the younger patients do get TAVR versus surgery. Now, remember the Notion 2 trial was a trial of patients less than 75 years of age and low risk with a bicuspid or tricuspid. And they basically showed that overall, there was no difference in outcome in the primary and secondary surgery versus TAVR. Just concentrate on the height of the blue and red bar, which is the death, stroke, and so on. Of course, we know the pacemaker will be higher with the TAVR, AFib, and all those things will be will be higher with the surgical valve. So then, in the tricuspid valve, when the tricuspid cohort identical, surgery, all the outcomes were identical, the main outcomes basically. But once you go to the bicuspid in young patient less than 75, you see a big difference. Big difference in favor of surgery compared to TAVR. So clearly, this was not a directly bicuspid randomization, but within that group, which made about 1/3 of the cases, the bicuspid cohort did not do any good compared to surgery. Although matched data, which have been published in the past, was Raj Makkar in Lancet and showed that both have equivalent outcome. Gilbert, what is your comment on this?
Yeah, no, I think that obviously, surgery has an upfront hit, on several
I see the TR.
And we've shown that even in the partner trial would be very, they're very safe. I think the question is obviously we talked about the prosthesis-patient mismatch and the durability. That's really what we talked about. You can see that here in this bar graph.
Yep. Pedro, you had some question about?
No. Yeah, well, there is another question, but we'll discuss it.
No, you can ask the question now. No, if somebody asking, that's better.
Yeah, very good. So the question is, I think, already answered. When is the best timing to evaluate the MR? When it happens immediately after or when it gets worsened?
After 30 days. Remember, at 30 days, they come back, we see the patient. At that time, we evaluate. That's the time we normally make the decision. Here, Gilbert already is saying that there is some primary pathology.
Not sure.
Yeah. So
there
it
is
could
a
be, right?
pseudoprolapse. Not really sure that that's truly primary.
So it may or may not. Yeah. If it changes or no, but at 30 days, usually we come to know. Yeah.
Okay.
Rare situation, we bring them back in 3 months. Also.
Excellent.
Okay. All right. So now, so therefore, clearly, so now we actually have another data of the balloon expandable valve from the TVT registry in the low risk cases in the younger patient. What basically younger patient means? The from 19 to September 2023, SAPIEN family, less than 65 and 65 to 80 were compared, and you can see less than 65 makes about half of them. 65, and you can see 52%. And so does happen. And clearly the still number has not increased. Actually, that's interesting. Some cases, yes, but question is why? And this all happened largely because of their comorbid condition. Look at this. Younger patients have more dialysis, COPD, home oxygen, hostile chest, immunocompromise, multiple heart failure. So because of that, and prior surgery, just like this patient, prior AVR, prior stroke. So younger patients are getting TAVR because of the high comorbid conditions, and I'll show you in my take-home message what it should be in this day and age. Now, overall, what did it show? That younger patient, the mortality in the younger was 9.9 versus 8.2 in the older patients. Show that higher mortality in younger patient, but if you propensity match, it's identical as shown on the right side. Now, individual endpoints are shown here. The stroke is lower, vascular complication lower, less permanent pacemaker, but higher readmission. Younger patient, why higher readmission? Not the valve related, because we know 70% of that readmission are non-valve related. So higher readmission with the younger patients and so. And this is the clinical outcomes in these patients. Basically, the same message comes out that the US patient receiving balloon expandable TAVR for severe AS in the low surgical risk era, those younger than 65 years of age represent a small subset. The patient younger than 65 had a high burden of comorbidities and incurred higher rate of death and readmission at 1 year compared to their older counterpart. Except CVA was lower. these observations suggest that heart team decision making regarding TAVR for most patients in the age group is clinically valid. Now, we also know asymptomatic. Remember 2 trials, the Avatar and Recovery, all showed that wait and watch policy does not work. They should have a surgical valve replacement, and we have the early TAVR trial also showed there. So clearly we understood. Young age, questionable. Bicuspid, questionable. Asymptomatic, go for TAVR, both surgery or TAVR. I mean asymptomatic, yes, surgery or TAVR. Now of course we'll go for surgery. But some cases will go for surgery, majority will go for TAVR. Evolved based on the patients who have a myocardial necrosis, still like in no overall trial was negative, but there was no harm in it. There was lower readmissions and so I think every patient you can encourage the severe asymptomatic aortic stenosis should undergo replacement, ideal cases, younger patient, surgery, bicuspid, surgery, and I would say probably 75 years and above, and non-bicuspid, and those who are going to live less than 10 years should go for TAVR. Now, so therefore, as you know, that guidelines, particularly with the symptoms and no symptoms, now we actually have 2 surgical trials, one TAVR trial. All have shown that in no symptoms, but patient severe aortic stenosis, I'm sure this will become soon a guideline with a class 1A indication soon. Now, second point is that what if patient has a significant CAD and severe AS? And this is a question very common. We know that 50+% of patients with the TAVR, with the aortic stenosis also have a multi-vessel CAD. So this question, should they go for PCI plus TAVR or should go for surgery, CABG plus surgical valve replacement? The first data we got from the registry from the Spain. And what they did, overall they looked into the cases. Of course, a patient with a TAVR with much higher risk than the surgical, but then basically they followed the patient, and you can see here the height of the red bar is the surgery, height of the blue bar is your TAVR. Percutaneous versus, I would say, surgical versus percutaneous approach. The lower complication, lower event rate with the transcatheter percutaneous approach compared to surgery. In every aspect, lower stroke, lower mortality, and so important is lower mortality. You can see there. Now, and of course, the NYHA and aortic regurgitation were not much different, and this was the central figure overall showing that there is a lower mortality in the transcatheter approach compared to the surgical approach. You say, well, this was just from the registry. Therefore, despite a lower baseline risk, CABG plus surgery in patients with severe AS and CAD was associated with a higher rate of death and stroke compared with PCI plus TAVR, highlighting the necessity for a large randomized analysis. So this was the registry. So let's say we do the trial. So as they wanted, we did the trial in Europe called transcatheter valve and vessel trial, TCW, and I still cannot figure out what that W means. I looked into everywhere. Do you know what the W means here?
I think the 2V and make the W.
2V make the W. Okay, well, you answered it. I know.
It is
you answered it.
TCVV.
Yeah, I know. I never thought about it. I tried to look into everywhere. Where is this W came from? V. There's a 2V became W. So thanks for updating me, but because I wasted about 1 hour to figure that out. What was the TCW? Okay, now let's see there. So concept are the same. Multi-vessel disease, severe AS. Do a FFR guided PCI plus TAVI versus CABG plus surgical valve replacement. And look at the dramatic zero death percutaneous approach with a 10% mortality in the surgical approach. Unbelievable, unbelievable. And every aspect of the in the blue higher compared to the violet, your brown color. Except the pacemaker, yes, of course, will be higher with our transcatheter option. So very, very interesting. So therefore, this field is evolving that patients, again, whether it will benefit, it will last for 5 years or 10 years, we need to see. But more important is that the field definitely changing in favor of percutaneous approach. Now we have one registry and one randomized trial. So therefore, the TC VV trial is the first trial to compare percutaneous treatment versus surgical treatment in patients with severe AS and complex coronary artery disease, showing favorably primary endpoint and mortality outcome with percutaneous treatment. Now, do you see this much mortality? 10%. I mean, they're not very old patients.
No, but it's high, and like you said, because the shift towards a lot of coronary disease are done percutaneously. There are not that many AVL CABG patients around to actually truly need AVL CABG. And we've seen that at the STS database as well. Now this year, Mount Sinai got the 3-star for that, but the N number is very low. So even one mortality will hurt your outcomes, significantly. So that's probably why.
Also, the cases going for surgery already have very severe coronary artery disease.
That's right.
One selection bias.
Correct.
Extremely calcified.
No, this was randomized.
Tortuous. So even in randomized AK, I mean, some of these cases are, are pretty challenging. So.
No, registry is pain just kills the whole registry.
Yeah. I would say it's a lack of experience, because so-called taking care of coronary artery disease has become percutaneous. So going for a bypass is not. Even in your registry data, the STS score and syntax score was equal.
Matched in the match group.
Yes,
in the match group.
And syntax was about 23 to 26.
Yeah.
Not very high. Not too complex.
Then this publication from our group with the 1-year outcome of the 5th generation with AK, basically comparing the SAPIEN Resilia versus earlier SAPIEN group, showed better outcomes, lower PVL, lower mortality or stroke. And of course, we need to see at the long term how it's going to behave. Now, the big thing could be this 10-year time frame which has come for valve degeneration, and the surgical data have shown that Resilia used in the surgical valve has a very low degeneration, and we are using Resilia in maybe 3 years now. If this can be extrapolated to 15 years, that the TAVR valve will last 15 years, I think the whole dynamics when you should be using as a class 1 instead of having 65 may go to 55 or so will happen. What are your prospects from the surgical point of view? Resilia, which has been used now, they say almost 8 to 9 years. We are only 3 years.
Yeah, I mean, we have to see what the time points is. The reality is that more TAVR being done than SAVR. So you're going to see more Resilia in a TAVR platform than SAVR. So we'll have to see how they come out with time. I think that's going to be the interesting part when they all come to see how many of the redo TAVR patients were previous generation versus the current generation.
And we also saw the lower gradient, right? I don't know what.
Yes, the lower gradient.
Yes.
But also less
definitely.
PVL. I think that is the key.
One big thing we are talking in Resilia is since Resilia came, we are doing the double inflation. And with second inflation, we definitely see a better expansion and your gradients single digit.
Okay. So then the second point, remember I talked about general anesthesia versus conscious sedation, and second was the balloon expandable versus surgical the self-expanding versus the SALT-TAVI trial. The 5-year data were just presented. Little complex, but basically as you can see here, that overall the top one, it's a very nice, very small, but the stroke rate is on the top. Only difference was slightly stroke rate was lower with the self-expanding versus balloon expandable, and the rest of things were identical. And for whether you general anesthesia or conscious sedation was no difference as shown in the lower graph. So that basically was SALT-TAVI overall outcome, efficacy and all were equivalent, and of course lower pacemaker with the balloon expandable. So therefore, transfemoral TAVR using self-expanding versus balloon expandable as well as conscious sedation or GA showed similar clinical outcomes at 5 years using a combined clinical endpoint. So therefore, like this particular case, where you have LV dysfunction, patient is unstable, they probably do an intubation. Otherwise, that's what we do at about 10 to 12% of cases.
Yeah, 15%.
Using the intubation and rest without. So, okay, so let's bring that total, our take-home message. We all try to put it together. In a patient with the symptomatic severe AS, a strategy of early TAVR is superior to the clinical surveillance. Also, TAVR in bicuspid less than 75 years of age has higher event rate, so surgery should be done. Then, recent data have also reported higher mortality and readmission, but lower stroke rate in younger patients Hence, a detailed, valid heart team discussion should take place in selecting TAVR in younger patients. So what I said is the CT surgeon has to say TAVR should be done rather than surgery. That's it. That's the true heart team discussion, in my opinion. The surgeons, like many of the cases which we do a complex PCI, left main, low ejection fraction, more than half are referred to us by the surgeons. Because they don't want to do it because of comorbid conditions. So it should be the same way. If you're doing a TAVR in a younger person, it has to be the surgeon saying it, go for TAVR, not for surgery. Second point, a randomized trial with N1 registry comparing transcatheter versus surgical option has shown better outcomes with the percutaneous strategy versus surgery, including lower mortality and stroke. So long-term data of 5+ years will be needed before adopting this strategy as a long-term, especially in younger patients. And then 5-year follow-up of balloon expandable self-expanding TAVR has shown similar results. As we shown, both are equal, so clinical decisions should be made. And then the TAVR with the Resilia valve is very encouraging. Again, if only question is, it could be a game changer in the TAVR field if it can also show lower valve degeneration at 5 to 10 years. Because whole thing, the 10 year is because of valve degeneration. If you can show, then can last 15 years, will be a great achievement in this field. So just 2-3 questions. A following statement not true about the results of the TAVR in younger patient versus older. Mortality is higher in younger patient, stroke rate is higher, readmission is higher, pacemaker rate is lower, and clearly the stroke rate is not higher in younger patient, it's lower. Second, the patient with the combination of the transcatheter versus surgical approach for AS and CAD or shown all-cause death was lower in the percutaneous approach, stroke rate was lower in the percutaneous approach, major vascular complications were lower in the percutaneous approach, permanent pacemaker is higher in the percutaneous approach. Clearly the vascular complications, because our sheath size is higher in the percutaneous versus surgical, but major bleeding will be lower in the percutaneous approach compared to the surgical approach. Lastly, our question patient is with a SALT TAVI, that is similar death between two valves, self-expanding versus balloon expandable, similar death rates between two groups, similar stroke rates between two groups, lower permanent pacemaker and balloon expandable, and similar PVL between two groups. Clearly the answer is B. In this trial, there was higher stroke rate with the balloon expandable versus self-expanding, only trial which has shown that. Every other trial, even PROTECT, there was a higher stroke rate with the self-expanding versus balloon expandable. With that note, I complete our presentation, and we can have any question and comment by our esteemed colleagues here.
Yeah, there is a final question here, just arrived from Dr. Parra in Colombia. He's telling us, Dr. Sharma, talk about the next TAVR and SAVR. You already did that, but just refresh this for the audience.
Yeah, so in this particular case, patient has a surgical valve. Then we are going to put the TAVR now. So whole question is that if you're deciding with the two TAVR, what it will be. So we all learn that you can still do two balloon expandable if necessary, but putting a two self-expanding is impossible. Why? Because the coronary issues and so forth. So in this particular case, we felt that if you do balloon expandable now, it degenerates in 8 to 10 years, then you put a self-expanding valve. So this gives the patient about 18 to 20 years. Compared to if you put a balloon expandable, self-expanding now, then that's okay. It may be a little difficult in, as Anu mentioned earlier, in navigating the catheter, but still will be the problem 10 years later. But key was that, and coronary obstruction is not the issue because heights were completely fine, so that's not the issue also. The only issue basically will be that now when self-expanding degenerate, you have to be very precise with the balloon expandable. It has to be like lower, otherwise very high chance of coronary obstruction. So we're talking about, that's why we try to show on those slides, node 4 versus higher. And I'll ask both Gilbert and Sahil, they actually really sat down and gave this, points, just one liner each on this, that why this approach is a little superior compared to other way around.
No, I think we already talked about exactly what Dr. Sharma said. It's lifetime management. It's a trade-off, and we don't know the durability of these patients with these valves. So I think a shorter valve first strategy is the best one in terms of giving all the options to the patient.
All right. With that note, we complete our presentation. Thank you.
Very good. So Thank you so much for the heart team and this extraordinary case we discussed today. Thank you for joining us. Remember, in ccclifecases.org, we have this case and we have all the other cases that we have done. And most importantly, for 2025, we're doing this monthly. It happens in the second Tuesday of every month. The next one will be February 11 at 9 a.m. Thank you so much.